Hi everyone, Marina Kurian here. I want to thank the program chairs and SAGES for allowing me to present today on endoscopic bariatric procedures. And I am going to share my screen with you guys. And okay, so I do have some disclosures on how to get started with an endoscopic obesity practice. However, my disclosures are really not completely pertinent to this discussion, other than I have some slides from Dr. Rachel Moore because she has started her own endo suite with her colleagues, and so there's some slides that are really pertinent to doing that. What we're doing with endoluminal, as you've heard likely before, is that we're offering therapies to people who are not eligible or don't qualify for surgery, or that they're just not ready to consider surgery and they think it's too drastic a step. In addition, there are patients that are already in medical programs with our colleagues that need additional help, and so endoluminal obesity treatments are an appropriate next step. And these therapies are not competitive to a bariatric practice, but more additive, and sometimes they bring patients in that you wouldn't actually normally see. So when we start a program, it's very important to look at conversion of patients to actual consultation. So when somebody calls, it's important to have an immediate response and get them on the schedule within that week, or even as early as you can within the next week. You want to have a dedicated person or a call center, and you have to have a very well-developed script with a lot of training on key patient questions relating to safety and efficacy of the procedure, and also costs, since many times insurance does not cover. And again, let's remember that over 68% of the population in the US is either overweight or obese, and that's a lot of people, and there's no way that we could even take care of this number with just by doing bariatric surgery. So we really need to fill the treatment gap that exists between diet and exercise and weight loss surgery. So this is just an industry market research slide which is showing that how many patients are would be qualifying for surgery versus who would actually be interested in weight loss or open to non-surgical. So non-surgical is 32.3 million, and that's quite a bit. And then at the bottom, there's the lowest, which is the number that's in 11 million, that people who meet the criteria for having some disposable income and then would also seek out additional treatment. And what are some of the things that are out there? Intragastric balloons, which you've heard about, endoscopic slit gastroplasty, endobarrier, fractal, which is really duodenal mucosal resurfacing. And also coming down the pike is something, magnets that are going to create intestinal bypass without surgery. But the most important thing in all these, and as you've heard about the risks and benefits from the other lecturers today, is we're looking at what are the complications, what are the outcomes, what adjunctive measures do you need in your practice to help take care of the patient, how much time are you spending on the patient, and is it enough to keep your existing staff? Do you need to add? So those are all important considerations when you start. But if you think you're ready and you want to get going, but you don't know where to start, so I'll just say that if you're not doing any endoscopy right now, you should start doing intraoperative endoscopies. If you're already doing intraoperative endoscopies or your own diagnostic endos or therapeutic, you may want to add to your skill set by taking some of the advanced bariatric endoscopy courses that are offered by SAGES and ASMBS, as well as a couple of different programs in the country. Mike Ujiki's is one, and Lena Kaitan's is another, where you can get some bariatric endoscopic advanced training. What I've done is I manage complicated cases sometime in the beginning with GI or thoracic, something that you can do. And you can also, once you've done some of the advanced procedures, you can take the BSAFE exam, which may help you in terms of getting credentialing, because what this BSAFE exam, which is offered by ASMBS and SAGES, is an assessment of skill in bariatric endoscopic techniques. So my path was general surgery, in my endoscopies in my general surgery training, endoscopy in the operating room. I also dabbled a little bit in transnasal endoscopy and did as well endoscopy for my revisional cases that came through the door, looking at pouch size and trying to determine stoma size or sleeve size, because as you guys may have experienced many times when you send the patient out to the GI docs, they're looking for pathology, and what we're looking for is perhaps technical failure of the operation. So different perspectives when we want to know the size of the pouch, if there's a lateral extension, the stoma size, how big the sleeve is, if there's retained fundus, etc. I also did Rose procedure early on when it came out, but then I stopped doing that also because they didn't offer that for revision of the gastric pouch and stoma. But then I also worked with that company on esophagus and doing TIFs with one of the GI doctors, advanced GI guys that referred patients to me, and we worked together. Then I started doing overstitch for pouch and stomal reduction, and then I had intragastric balloon training. And then part of all of this is also marketing. And one of the good things is that when you do these trainings, these companies will put you on their website, especially if they're doing DTC or direct to consumer marketing, then you will be contacted as someone who participates and is aware of the procedures and also performs the procedures. But it's most important that if someone's calling you about that you have to do the follow through. So tips for success, I would say you have to have a website, preferably one that already has traffic. Make sure that you do search engine optimization for the procedure. The company again lists you as your practice as a trained physician in the technique or in the procedure. Staff has to be educated and engaged and interested. I find that it's very important to have one contact person in the office other than yourself, and sort of like a Sherpa that'll take the patient through from start to finish. Very important to have a quick response to patient concerns, because happy patients will send you more patients. Medicate these patients post-op as needed. I also medicate with weight loss medications during some of the procedures to maximize their weight loss. And then if they get into trouble, you need to consider being able to send them either to an infusion center or have IV fluids in your office to rehydrate them if this is one of the side effects of the procedure. And don't forget also that even though we're doing endoscopic procedures, if these patients are throwing up a lot, the thiamine is also critical. Advertising, I didn't do a lot. I mean, when I did gastric balloon, I did do a TV spot for it. Otherwise, Google ads is what I usually use. Facebook ads work in some markets. I don't believe they work in New York. Google reviews, though, are free, and if happy patients, if they can fill those out for you, that's really great. So happy patients really means a happy practice. You get referrals from other patients as well. And one of the things that I found, especially with the balloons, is that pre-medication was completely a game changer, and giving patients EMEN to counteract their nausea and vomiting was really important. And postoperative, very important to make sure you know which drug regimen to give patients before you embark on endoscopic obesity treatments. As I said before, I early on did work with GI as well as thoracic when I had complicated bariatric patients. And so I had established that rapport with them. And it may also be appropriate for you to initially collaborate with one of these docs or another surgical colleague as you're growing your practice. And mainly, you need coverage if there are complications. So it's important to have at least some buy-in from whoever's covering you or from another colleague who will cover you when you're out of town or not available. You also want to gauge the level of the interest of the other colleague, meaning I've had GI guys who want to do the procedure, but they don't want to do the follow-up, and they also expected me to bring the patients to them. And that was not what I wanted to do, because I had the skill set to do the endoscopic procedure. So I didn't necessarily want to engage in that level of collaboration. So you need to look at if it's going to be one-sided or you both marketing and bringing patients. You have to price this for success, your cost in terms of whatever the product that you're buying, cost of staff that you're dedicating to this, cost of follow-up, how many phone calls are you making, how many post-procedure follow-ups do you have to have. Is your malpractice insurance for bariatric surgery going to, it won't go up, certainly, but my point is, if you're making like $500 on these procedures, is it worth the time commitment for what you're actually paying for your malpractice insurance? So you kind of have to look at that and weigh it. If you are already doing endoscopies and you get part of a facility fee, or you work at a surgery center that does endoscopies and you're getting part of the facility fee, then this is a no-brainer. This is actually added money to you, so it's worthwhile to do it. Some people have considered making their own endosuite, building their own, and there's a lot of things you have to take into account, which is construction costs, maintenance costs, employee costs, and volume of procedures. And again, this is something that Dr. Moore had really looked into, and this just shows you how they break up the endoscopy and colonoscopy times in the suite, and it looks at how many days a week they're running it and what the issues are. And when you're paying people for the day, it's very important to start on time. Otherwise, that's wasted money because of personnel costs. So this is just another look that she had of what the costs are, projected volume. So this is just part of your business proposal. And then, you know, so for Dr. Moore, this was exactly what they were paying per day. And so personnel, she felt, was one of the biggest expenses. And it's very important to schedule them effectively. Make sure you have your cases loaded for that particular day, and then make sure you're on time so that you can get through the day. The other things that she brought out at one of the lectures that I'd seen her giving is that you have to have an appropriate waiting area and a check-in site, a staff area, you need an endosuite, you have to have a scope cleaning and dirty utility room, storage space, and then of course you have to pay for licensures and certification. So that actually comes out to be a big nut. You really need to have your business plan in place and look at what your break-even point is for doing endoscopies. You might think that this is not something you want to get into, but there are going to be new endoscopic therapies before the FDA that may be more appealing. And I think something else to think about is, what are the complications? Because if they are severe complications, that's going to obviously affect your adoption of something new. So it's very important to really look at what the data is before you incorporate. And also, how easy is it for you to bring it into the practice? How easy is it for patients to deal with post-procedure? Because that will also impact adoption. And again, look for a break-even point, especially if you go the route of your own endosuite. And make sure your staff is prepared to answer questions for the patient. So you really have to go through your phone tree or your script to make sure that they understand what is entailed. I like to have an office Sherpa, so there's one person that my patients go to for all these questions, and then make sure your price point on the procedure is good for the level of time you're putting in, the level of commitment of office resources and your staff. Thank you.